Welcome to Only Oncologists in the Building. I'm Shalan Big. I'm a medical oncologist based in Dallas, Texas, and I'll be talking about how nutrition can impact dementia risk.
I'm Shruti Patel. I am a medical oncologist in the Bay Area, and I'm going to be talking about the tumor microbiome and how it's different in early onset colorectal cancer versus average onset colorectal cancer.
Emil here out of Minneapolis at Cancer Assassin 1. I'll be reviewing COVID. What are the potential repercussions for patients with cancer?
So, we all know that a healthy diet can be good for our brains, but what if I told you that the impact that that diet can have isn't really the same for everyone? So, today I found a study which evaluated the impact of diet for Alzheimer's disease risk. They took 5,700 people and they found that a person's genetics, so specifically ApoE4 gene, it fundamentally influences how their body metabolizes certain fats and lipids. So, in turn, that can affect that person's risk of developing dementia. So, they found that people who have ApoE4 homozygosity, so both of the genes are at high risk, they have a distinct metabolic profile, and their bodies process fats differently, have a unique profile, and that can be influenced by external factors like diet. And they found that a Mediterranean diet was particularly effective in shifting their dementia risk, but it was not seen in people who don't have that mutation. So it's not a broad health recommendation. It's taking us more into a world that a personalized approach to nutrition or precision nutrition could be a powerful tool in preventing Alzheimer's disease for those who are genetically susceptible. So it's not a one size fits all approach. We've known that eating healthy and eating the Mediterranean diet has different effects, but that's not very consistent across different populations. And one of the criticisms for Mediterranean diet is, I mean, if you go to Olive Garden and you have food over there, like, does that qualify as Mediterranean diet? But for those interested in the details, the study used a scoring system. So they had done surveys on people who had enrolled in a couple of large cohorts back in the 90s and 80s. And then they looked at those patients' diets and they calculated a Mediterranean diet score. And they looked at different intakes for nine different food components. So they looked at their intake for fruits, vegetables, nuts, whole grains, legumes, and fish. And you get a point if you have those. You get a point less if you're eating a large amount of red or processed meat, and you get an added point if you're drinking 5 to 15 grams of alcohol, continuing with the possible benefit there on previous studies for coronary artery disease. So that's the score that they used, and they did longitudinal assessment, and they found that those who persisted with a high score in their Mediterranean diets and had this specific genetic susceptibility were able to alter their risk of developing dementia, and that diet didn't have an impact on people who don't have the mutation. So I think it opens the door to a very different world when it comes to diet and recommendations, because I think all of us in clinic dozens of times a week, we talk about eating healthy, we talk about less red meat, we talk about these aspects, but it's much more nuanced. And I want to bring this up for a discussion and see what your all's take are.
Yeah, so my take is really just that I feel like every time a study comes out, the Mediterranean diet gets like more powerful. It's almost like it's like I'm thinking like Transformers or something. I don't know. It's just like when you brought up that you were going to talk about this study, I was like, what can the Mediterranean diet not do? It was like my first thought. And like, I just feel like, when all the Power Rangers assemble or anyways, but I think that all of this evidence is extremely important to come out, even though, we hear about Mediterranean diet, oh, it's so good. Because as much as we say, like I tell all my patients that the Mediterranean diet is good for them for cancer risk and all of those things, do I eat a Mediterranean diet? Perchance not is the answer to that, because life is really busy and it is much easier to eat processed foods and grab them and, like, we have work, we have obligations, we have life. And so I think the true value of these studies is hopefully in aggregate, we're able to convince the industries, like the food and beverage industries, really to make things like the Mediterranean diet more accessible. Now, of course, I realize capitalism exists, so I don't know if that's actually going to happen. So
Yeah, I think you're right. I think the comparison and contrast or American North American lifestyle, it's been made for years. I think the Mediterranean diet is like my favorite. I love so many things about Europe. I'm a Europhile. But I think if I put on my amateur epidemiologist hat, I shall truthfully about this Mediterranean diet and so many studies, right, in cardiovascular realm, oncology because we deal with oncology so often, and those are the questions we get. As a mantra, I always say exercise is the best nutrition. This is no magic food, but this mystical aspect of the Mediterranean diet, I think, is not just what people intake, but although the individual components, and you mentioned 7 or 8 categories, Shalon. There's tree-based nuts, there's the fruits and the vegetables. What I've noticed, and in instance at various parts of my education, kind of living in long stints in Europe, what I found was it's not just what they ate, it's how Europeans eat, right? And so we integrated into that, a lot of studies in around France and Spain and other countries in Italy that surround the Mediterranean. People really take their time eating. And of course, in contrast, and of course, a wide swath of dietary habits in America, but it's the amount that they eat. And so caloric intake has to be taken into that. So when I think of association, correlation, and causation, all things like that, I think of studies like this, if they were negative and didn't show any difference, then you kind of drop it. If they say there's a potential, you can say association and potential correlation, then there's more of a thread to pull on to see what other potential confounding factors. At the end of the day, you can't go wrong trying to have a balanced diet. And I would say even, kind of a day-to-day basis in clinic is saying being active rather than sedentary, avoiding alcohol, avoiding tobacco products and drugs. It's more, in some measure, also balanced out by what people don't do, but also what people do. And Mediterranean diet, I think, has a lot of potential, but it definitely, as you said, not one size fits all. It's not that if you do this, then this is exactly how you can avoid Alzheimer's disease, cancer progression. We saw at the ASCO annual meeting with the big study that got a lot of play in the post-operative setting for stage 3 colon cancer. The report concluded that trial, as a prospective trial, was well done and extensive, concluded the exercise really reduced that risk of recurrence. I think these kind of studies are fascinating. We just have to kind of consider other confounding aspects of it and see how to go forward.
Yeah, and when we talk about Mediterranean, we're also talking about North Africa, we're talking about Middle Eastern diets, and we're not necessarily giving a prescription of pizza and pasta as a definition of, and I love my pizza and I love my pasta. So just to recap, fruits, vegetables, nuts, whole grains, legumes, and fish is what they were calculating in terms of total amount.
I wanted to make a comment about the alcohol component, and I think it kind of relates to what both of you said in a separate way, where you said that alcohol added a point, right? They got a point for the alcohol. And now, of course, like, I don't think we're as gung-ho about the glass of red wine to save your heart as like a medical community as we were probably when they were doing the study. And obviously this was over years. But additionally, I wanted to link that to your point, Emil, about how we consume, not just what we consume. And maybe this is probably the next study I'll talk about next week, where binge drinking versus drinking with meals confers a differing risk for early onset cancers. And so it's really interesting. It's not just to your point about what we drink, but how we drink also, or, what we eat, but how we eat. And so I just wanted to make both those points.
Absolutely. All things in moderation. I learned years ago, very early on in my post-fellowship practice, that if you ask as a physician, relative subjective terms like a lot, do you drink a lot? Do you smoke a lot? People say not that much. And I once had a response that 1 case of beer per day was not a lot, because previously this gentleman confessed that not hiding anything, he confessed he used to drink 2 cases of beer per day. That was a lesson to me. I'm like, well, I think I have to work more on quantitative, objective questions, how I approach it, because not a lot could mean a lot of different things to different people. Just as an aside, the thing with alcohol, especially, I think going back to at least 2017, ASCO, our professional organization, and others have come out and really, I think, spoken out more strongly. And Shalon, you could speak to this better than I can because you were involved in these statements. That basically spoke more strongly than I had ever heard, at least in the cancer world, about alcohol being a carcinogen, whereas before maybe associated with, or we'd learned in medical school, I think all of us, if you smoke, you have X amount of risk for head and neck and lung cancers. If you drink and smoke tobacco, then it's synergistic, maybe a 50-fold higher. But I never heard such strong words until the last half decade or more. So maybe you can comment on that. Certainly our cardiovascular friends, at least when I was in training, spoke very strongly about it, and studies funded by the wine industry, but it's a different aspect of it. But maybe speak to that and how that plays into this study and their commentary on it.
I think I'll recap this study and answer your question at the same time, because I think we're moving to a time where we will understand at an individual's level, individual's risk level, and their own genotype and their own living scenario on how how to counsel regarding nutrition, and just saying eat more fruits and vegetables is so 90s. How do we, because maybe a certain amount of alcohol in this example can reduce a risk for one risk factor, but worsen someone's health in different ways. So in cancer, we know there is no minimal amount of alcohol that is deemed safe. Even mild alcohol consumption can increase the risk of certain cancers. So we're moving into a field and we're moving into a time of precision medicine so that we can start offering specific treatments for different people. We talked about precision chemotherapy last week, where we can measure someone's risk of side effects from chemotherapy and give doses based on one's genotype. And now we're moving to precision nutrition, where we will enter a world where we can counsel individuals based on their own genotype, their own phenotype, their own cultural scenario. You can't tell someone who's living in the mountains in South Asia to eat a Mediterranean diet if it's not culturally appropriate. So these are all factors that we're going to have to start thinking about. Really exciting time when it comes to counseling for nutrition. So great conversation. Shruti, what do you have for us today?
All right. Wow. That was so interesting also, by the way. Okay. So I have a study that, first of all, I think we've all heard about the gut microbiome, right? And I feel like everybody talks about it all the time. I was fascinated to find out a little bit more about the tumor microbiome. So this was a study done in Cleveland Clinic. Essentially, they used RNA sequencing to investigate in these like frozen samples that they had from early onset patients with early onset colorectal cancer, and compared them to average onset colorectal cancer. And what they found was that the tumor microbiome, so the bacteria that they found within the tumor, were different. Certain ones, of course, overlapped, as you probably expect, but the younger onset ones were enriched with one of the bugs, Akkermansia, and Bacteroides was the second one. And then the average onset tumors had they had quite a few more enriched bacteria. So I'm going to look at the list. Bacillus, Staphylococcus, Listeria, Enterococcus, Pseudomonas, Fusobacterium, and Shigella. But I think the part that I found very interesting was that Akkermansia, which is the one that was enriched in the early onset, it's a mucin-degrading bacteria, promotes mucus thickness within your gut barrier. And so, because of some of this research that kind of showed that, this bacteria promotes gut kind of mucus healing, some companies have been selling Akkermansia supplements in hopes to reduce people's risk of colorectal cancer. And I think it's interesting because it really tells us that the gut microbiome and the tumor microbiome, they're not quite the same thing. And so I just think that there's a lot of caution when you see studies like this, because even though I will say Akkermansia abundance within the tumor was associated with an overall survival benefit, which is cool. I thought that was pretty cool. And you wonder, could Akkermansia supplements in patients who have colorectal cancer help them in the future? Of course, these are all questions. These are not, I'm not endorsing this in any shape or form. But I think it's such an interesting, first of all, field, because I really didn't know much about the tumor microbiome, which is separate from the gut microbiome. And I want to specify that in this study, they compared them to samples from the rest of the gut. So they had the tumor microbiome, and then they compared. And so when I say it's enriched for Akkermansia, it's enriched from the sample that was from, a non-tumor specimen from the same patient. So I thought that was I think it's an interesting study, because I think that there's so many ways in which we can intervene, right? Whether it's, obviously we have molecular landscape, how do we intervene by targeted therapy? But is there a way to intervene with microbiome changes? And so, yeah, I just thought it was a really cool study. And there's obviously so much work to do before you can start selling supplements and telling patients, you should take those supplements, it'll help you. But I hope we can eventually figure that out. What do you guys think?
I guess a big question is that a company or companies selling the Akkermansia supplements, did they do that ahead of the study, or did they fund the study, or just be quick on the draw to start making it and packaging it?
They did it ahead of the study. So essentially, they did it from, we know this because we've experienced this with a lot of different preclinical data where, there's the data that show that Akkermansia helps maintain the gut, right? So in studies and the gut barrier integrity. And so these companies are like, yeah, people will buy this if I say that it'll help maintain your gut barrier integrity. And so, yeah, this is pre-study. People were selling it, and it just, every time we have a study, and I know that we'll talk about it with yours too, if it confirms something that people are already believing, right? But it doesn't fully explain or confirm clinical benefit or anything like that. That's just going to be used to sell more of that product. And so that's why I say I give a heavy amount of caution when I say that this is cool, interesting data, but we have so much to learn.
Yeah, that's my worry about all microbiome studies as they stand right now. It seems a couple times a week we're hearing a new study which is telling us how the gut microbiome can affect our health. I think all three of us would agree that the gut microbiome does play an impact on our overall well-being. Where we may have differences of opinion is what that impact is. How do we measure what the gut microbiome really does? And what outcomes are we trying to modify? We did a study many years ago that showed that certain bacteria gave an individual a higher risk of developing immune therapy side effects. But then there were many other studies that refuted those claims. When you look at the data that comes out from these microbiome studies, the huge amounts of data and how these associations are made, there's tremendous potential for bias in our evaluation in the hypotheses that we're testing and just in the statistics in general. My worry about the microbiome field is that we're going to kill it before it even starts. You presented, Shruti, last time on how exposure to a certain bacteria in your youth can impact cancer outcome down the line. How does one even measure and move those forward? So I take all microbiome studies with a huge grain of salt, huge pinch of salt, and I'm very skeptical about the data because, in general, not this specific study that we're talking about, because oftentimes there are people who will not have a complete understanding of the study and the findings, and they will rush to give recommendations, which we know based on past history can sometimes even cause detrimental side effects. We saw this with fish oils. We saw this with vitamin E supplements causing increased risk of cancers when we were trying to do very well-intentioned studies. And that was an example of not understanding the entire biology and rushing to specific solutions. But very exciting space. I just don't think it's influencing the care that we're giving our patients or how we're leading our own lives.
In conclusion, continue with your daily cup of yogurt. Chobani, Yoplait, Dannon, feel free to sponsor us. We acknowledge the microbial supplementation that is safe in yogurt relatively. Yeah, no, it's very hard. I think it was Enterobacter last time, and then fusiform bacteria that you also mentioned, Shruti, among that alphabet soup of bacteria was in that mix and has been implicated with colorectal cancer, whether it's something that stimulates, maybe by itself or an association, young adult or colorectal cancer in general, or if it's when it's there, then somehow activated to make some cases worse than others. We still don't know. I think this idea, their strategy of investigating microbiome, whatever it's composed of, inside the tumor relative to what's in the gut is fascinating. And maybe it's all there, and you eat a Big Mac or even maybe something healthier. The proportion is constantly shifting, probably on a daily basis and month to month and year to year in everybody's guts. But I wonder whether it's a proportion amount that's in a nascent tumor, growing tumor, a tumor treated with chemotherapy or immunotherapy then becomes refractory. That it makes a difference if people. I would say we need our friendly neighborhood bioinformatics, computational biologists, gurus on this, because to tease out one, let alone an entire dozen set of gene signatures related to microbiome is a real challenge for that field.
Yeah, I think that there's so much we cannot learn from this, to be clear, but I really hope that there's something eventually that we do learn,
Absolutely. Emil, you're going to talk about COVID. Why should we still be interested in COVID today?
Yeah, so today we're very intestinally focused. Here's more about the gut. So if you didn't have enough about the Mediterranean diet, you didn't have enough about the microbes. So the microbes commented on were mainly bacteria. So now I'm going to shift a little bit to virus. That might have implication for gut bacteria too. But we're going to go back to COVID. So I know we're in 2025, we're 5 years plus past the onset of the pandemic in March 2020. But during that time, when we were all kind of having to shut down labs and wondering what to do and how to continue our research when we couldn't do hands-on things, we were also hearing a lot, at least in the oncology world, about patients with cancer were our focus, but people without cancer too were hospitalized with severe inflammatory reactions from this new coronavirus on the block, that variety called COVID-19, the SARS-CoV-2 infection. So it got to mind because it also was overlapping with what we see with cell therapies, which are mostly in the bone marrow transplant, hematologic blood cancer world of graft versus host disease, which are autoimmune reactions and reaction to treatment and so on and so forth. And so initially, I'm talking about research that came out of my own research group, published as of August 26th in iScience, which is a Cell Press journal, so check it out as a pre-proof version. But we're really excited for it to come out, and it came out during the peak of the pandemic. We wanted to initially identify patients with solid tumors and examine the ones infected with COVID, but not just infected with COVID with mild or moderate side effects, but so severe that they landed in the hospital. And so on top of that, we were trying to go through the database and identify patients in real time, but also identify what were the changes perhaps in their tumors or in their gut that we could identify at a genetic level. And so patients with metastatic tumors don't often have biopsies with good reason, but on occasion people might for different reasons. And so ironically, when we did the database check, the people who had biopsies before and after identified and test-proven COVID-19 infection ended up being 3 transplant patients, 2 of whom had hematologic liquid cancers treated with hematologic, essentially stem cell transplant, and 1 who had multiple solid tumor cancers, but a solid organ transplant. And so that's really, 3 of us know, but for everybody out there, that's really like the most immunocompromised of the immunocompromised. And so perhaps not surprising that they were severely affected by COVID. And again, it was before the vaccine, before Paxlovid or anything. So they're really severely ill. And the reason that they had biopsy specimens before and after was because the routine colonoscopy is done to test for autoimmune reactions that could happen in the post-transplant setting. And that was the reason why. So we kind of shifted the strategy of what we're looking at. So it wasn't tumors, but it was actually the gut. And what we found was that the gut, specifically the small intestines, were very specifically, very effective reservoirs, to put it that way, for the SARS-CoV-2 virus. And so for the duration, there was obviously variation between the 3 patients, how long prior to COVID infection they had their first biopsy and how long after. But these were all severely ill with autoimmune reactions that were basically fighting their body, despite their immunocompromised situation. The gut was a reservoir, and we did kind of fancy spatial transcriptomics. So the different specimens we subjected to looking at RNA evaluation very deeply, but in different pockets of the specimen. So these weren't tumors, but pockets of the gut that also the microbiome bacteria-wise also overlapped. And we identified specific markers that are actually known in cancer to be associated with higher risk. One of them was called serpin as part of a family of proteins that are involved that are normal but upregulated in cancer, like many things are. But we also looked through a database of patients, 600 patients publicly available through TCG and otherwise GI tumors, and found that same marker was upregulated. So it really identified for us components of the virus that were present even as much as a few months later in those cases. And that really kind of opened our eyes to this notion that COVID wasn't just something present at its worst in 2020. We know of trying to link this to common problems of 2025, for which there were RFAs by the NIH and NCI earlier in 2025, which unfortunately, coming back to this notion where research is not as strongly funded and supported in recent months, unfortunately, but there were calls for proposals to investigate long COVID. And we think this has strong implications for long COVID. If in the gut, it can harbor more latent forms of this virus that can blossom again and cause severe reactions again in our most immunocompromised patients.
Do we know if this is specific to COVID infections, or do other infections, bacterial or viral infections, do a similar hiding in the gut
Yeah,
reservoir?
that's a great question. That's a great question. Harkening back a long time ago, a place a long time far away, in a galaxy far, far away, during my PhD, I worked on oncolytic herpes simplex virus. And at the time, it was more of a gene therapy strategy for oral cancer, a different story. But the common thing, the reason I'm bringing up HSV1 is that's an infection that's permanent. Is any of the herpes virus families, like Epstein-Barr virus, coming back to the microbiome that could be in the gut. But these are known, like herpes simplex virus resides in the trigeminal ganglion, and it resides there. And then there's a different expression of RNA that for latency. And at times of stress, that's when it burgeons and creates and manufactures more live virus and comes out. And it causes the common cold sore or the genital herpes or whatnot. But 80% of the population at least has been exposed to it, has antibodies to it, but not everybody has active infection. And I kind of think of it in that light, Sean, is that COVID at its worst, when someone's at their most compromised, stressed, maybe undergoing chemotherapy for returning cancer, where maybe when they're critically ill in an ICU, is that when COVID's going to rear its ugly head? It was there, never really went away, despite Paxlovid, despite maybe repeat vaccination in some folks, and then come out because someone's immunocompromised and their body's stressed again. So that's our worry. And so it's really kind of the tip of the iceberg. I think it's probably creating more questions. And I do hope that we can have opportunity, or others, to also investigate it with the implications of long COVID and how it affects the brain and memory loss and so many things that we've discovered since 2020 that might be long-term causes of symptoms that could be traced back to COVID.
Yeah. I had the exact same question, which is that, like, what about the flu? Does the flu do this? Do any of the other coronaviruses do this? It'd be really interesting to understand that. But I mean, I think that we've seen enough long COVID to know that there is something going on that we really need to understand. And so seeing this as a first step to understanding, like, okay, well, it's living there. The question is, you investigated this in people obviously that are immunocompromised. Does your immune status, or how like functional your immune system is, does that contribute to you being able to clear the virus? So in someone like us, like you or me, have we cleared the virus completely, or is it living in everybody's reservoir, right? And if I were to, knock on wood, become immunocompromised, would it be able to rear its ugly head? Right. Or is it like HPV where, your body clears it sometimes and sometimes it doesn't? So anyways, it's an interesting...
Yeah, HPV is a good example of clearance with antibodies, except in the most immunocompromised population. So unknown.
Yet in HPV, prior exposure, even if you clear the infection, can lead to continued increased risk of developing malignancy decades later. And that'll be a very interesting line of research for what you've discovered in your research, that COVID viruses could continue to persist in reservoirs in the intestinal epithelium, and what that risk could mean for individuals maybe decades down the line.
Right, absolutely. So I don't leave it unsaid, just to make sure for all the listeners, no way implying, the study does not imply, and I have not said, or am I saying that COVID-19 causes cancer. Just want to make it absolutely clear for any sound bites that might come out of this or in the comments. In the comment section, comments are always welcome, constructively, hopefully, after people subscribe to our channel for watching our episodes. But I just want to make it clear that the study does not state whatsoever, and I am not saying that COVID causes cancer. We're talking about 3 patients with history of cancer, immunocompromised, especially because of their history of transplant. And this was 5 years ago, at the kind of the worst pandemic, pre-vaccine, and so on. But the study comes out now because we were able to bring it to completion. Again, I acknowledge it creates more questions than answers. All the questions we heard today are really good, and we hope to have the opportunity, if funding presents itself, hopefully to be able to pull out thread some more.
And our goal is to get the most recent and most interesting research studies to our audience and tell them how those studies can impact their days and how they should modify what they're doing or not modify what they're doing based on the discoveries that are coming out at neck-breaking pace. So that's all the time we have for today. Thank you very much for watching, and thanks, Shruti and Emil.